Good morning, everybody, and good afternoon, good evening to all our colleagues around the world. Welcome to today's discussion on Conquer the Clot, addressing VTE in your patients with cancer. I'm privileged to lead today's faculty. My name is Alok Khorana. I'm a medical oncologist at the Cleveland Clinic, where I direct the GI cancer program, and I have a special interest in cancer-associated thrombosis. I'm joined today by my colleague, Michael Streiff, who's a professor of medicine and pathology and director of the Johns Hopkins Anticoagulation Service at the Kimmel Cancer Center at Johns Hopkins in Baltimore, Maryland. And also by Tzu Fei Wang, who's an associate professor in the Division of Hematology in the Department of Medicine at the University of Ottawa and is an associate scientist at the Ottawa Hospital Research Institute. Welcome, Dr. Streiff and Wang. Today's learning objectives are to identify appropriate patients for VTE prophylaxis through risk stratification, establish a plan for prevention of VTE in patients at higher risk, select appropriate therapy to treat VTE in the patient with cancer and the duration of treatment, and to discuss with patients the risk and prevention of VTE. We want to thank our sponsors. This activity is supported by an educational grant from the BMS Pfizer Alliance, and we acknowledge their support and thank them for it. And if you have any questions during this session, use the question and answer section to submit your questions at any time. We've marked off several minutes towards the end of this webinar for the full panel to be able to answer your questions and have a robust discussion around that. So today's agenda is laid out here. Number one is to note the risk. Are your patients protected? And this discussion will be led by Dr. Michael Streiff. The second item on the agenda is critical care preventing cancer-associated thrombosis in your patients, and I will be leading this discussion. And to bring up the end, last but not least, Conquer the Clot, treating VTE in your patients with cancer, and this discussion will be led by Dr. Wang. And then finally, all of us will be available to answer your questions and have a discussion around some challenging cases. This seminar today will be interspersed with many questions, some of which we'll answer at the end as well. That will invite your interaction in terms of polling. So be prepared for that as well. So without further ado, I'll hand off to Dr. Streiff. Know the risk. Are your patients protected? Michael?
Thank you very much for the opportunity to present today. So I appreciate being invited to be part of the panel today. So I'm going to go over epidemiology, some of the latest data on epidemiology of cancer-associated thrombosis, and then look at the different risk tools, some of the different risk tools that are out there that we can use to assess our patients and determine who should be on thromboprophylaxis or who should be considered for thromboprophylaxis. So this is some of the latest epidemiological data about cancer-associated thrombosis, study from looking at the Danish medical registries and looked at the time frame from 1997 up to 2017. So this is really contemporary data. And what these authors found was that VTE is 12-fold more common in the first 6 months after diagnosis in cancer patients than the general population. In patients that are receiving therapy, this risk rises further to 23-fold more common than it is in the general population. As you can see in this graph to the right of this slide, that the risk since 1997 through 2017 has increased threefold in the cancer patient population, where there's only been a slight increase in risk in the general population. So cancer-associated thrombosis is a common morbidity and mortality that's becoming more common over time. Also important is that cancer patients have worse outcomes. They have more recurrent thrombotic events, they have more bleeding, and patients with cancer that develop thrombosis have a higher risk of death. So risk factors for CAT include patient-related risk factors, disease-related factors, and treatment-related factors that we know that as age increases, the risk of thrombosis increases. Ethnicity also influences risk, as do genetic polymorphisms such as factor V Leiden, and then comorbid conditions such as obesity can increase risk. The disease itself increases risk, that cancer site and histology influence risk, as does stage. The time from diagnosis is very important in factoring into risk, that patients have a very high risk of thrombosis right around the time of their diagnosis and following the start of therapy. And then tumor biology, tissue factor, JAK2 mutation, IDH1 status, protoplanin expression, and many other factors influence risk. And then finally, our treatments also influence risk, that chemo, radiation therapy, surgery, growth factors that we give to support patients, the central venous catheters we use to deliver therapies, and transfusions to get people through therapy all increase risk. So from this population study that Mulder and colleagues just published in Blood, you can see some of the typical suspects that are associated with cancer-associated thrombosis being very prominently featured in this graph. This is an incidence rate over 1,000 patient years. And not surprisingly, pancreatic cancer is has a very potent impact on thrombosis risk. But you also notice other tumors not necessarily associated with thrombosis risk, such as Hodgkin's lymphoma, non-Hodgkin's lymphoma. And then at the far right end of the graph, you see the patient population, the general population without cancer. So now we'll look at some of the data from that study I just highlighted that gives us some data to answer this question. One, as you can see, with older age, the risk goes up for thrombosis during cancer therapy. Previous VTE has an impressive, important risk increase, that it's 8-fold. If you've had a previous clot, you're 8-fold more likely to have a clot during your cancer therapy. Not surprisingly, metastatic disease increases your risk. As you can see, all the different therapies we give to patients for cancer increase risk, including surgery, radiotherapy, conventional chemotherapy, and targeted therapies. This is the time course on the impact of different therapies on thrombosis risk over the first 12 months after diagnosis. You can see at the bottom of this graph, you have patients that were not receiving therapy for their cancer, and then the different therapies: chemotherapy, protein kinase inhibitors, anti-angiogenic therapy, immunotherapy, and other targeted therapies. So perhaps somewhat surprisingly, these targeted therapies actually have at least as high a risk for thrombosis as chemotherapy. Because cancer patients are at high risk for thrombosis, there have been a number of studies conducted to studying thromboprophylaxis to try to prevent these thrombotic events, because they have such a big impact on morbidity and mortality. And I've selected two of the most important studies, the PROTECT study and the Tzu Fei Wang study. These both focused on unstratified general populations of solid tumor patients. PROTECT randomized people to either nadraparin or placebo in a 2-to-1 ratio, showed a significant reduction in thromboembolism with only a modest increase in major bleeding. Number needed to treat was 53. Tzu Fei Wang, the largest randomized trial conducted in thromboprophylaxis in ambulatory cancer patients, showed again an impressive reduction in thrombosis from 3.4% to 1.2% for patients receiving semulapirin. Number needed to treat was only 46. As you can see, very modest impact on major bleeding. Both these studies, very positive studies, but even so, and even with the impressive number needed to treat compared to, say, medically ill patient prophylaxis studies, these studies really didn't change practice, because you needed to still treat a lot of patients to prevent one thrombotic event. And so that means we had to focus on patients that were at particularly high risk for thrombosis. And so I'll now look at the different risk stratification models that help us do this. And the first of those was the Khorana risk score. As you can see, it identified, using the ANC registry, identified a number of risk factors for thrombosis, including cancer site, platelets before start of chemotherapy, hemoglobin or ESA use, white count, or BMI, and the number of points associated with how important, how significant they were at influencing risk. As you can see in the graph to the right, which comes from that paper, in the derivation cohort, that as the number of points in the score increased, you had an increase in thrombosis risk in the first several months after starting chemotherapy, such that within the first 3 months, 7% of patients in the derivation cohort had a thrombotic event. So an impressive increase in risk in high-risk patients. And then they used a separate group of patients in that ANC study to validate this, the rule, and showed basically similar performance. And it's been subsequently validated in more studies than any other risk model that we have out there. 55 cohorts of over 34,000 patients have been studied using the Khorana risk score. So now we're going to meet our patient, Mrs. Smith. She's a 72-year-old woman. She's presenting for her first oncology visit after being diagnosed with metastatic colon cancer. Her white count at start of chemo was 14,000, hemoglobin 11.5, and platelet count of 430,000. So let's watch our telemedicine visit together. So Mrs. Smith, we've now spent a good bit of time talking about how we're going to treat your metastatic colon cancer with chemotherapy. But we also should spend a little bit of time talking about some of the side effects of therapy. And one of those side effects is something called cancer-associated thrombosis. And why we're discussing this is because you do have several risk factors for developing a blood clot. Your white blood cell count is high, your platelet count is high, and you're anemic. Do you have any questions about what this is? I'm happy to give you more details.
I feel pretty comfortable with your explanation, but one thing I'm wondering about is what my risk is for developing a blood clot.
Sure. So cancer-associated thrombosis is are blood clots that develop in the veins or in the lungs. And with these risk factors that I told you about, it puts you at about a 7% risk in the first 3 months of therapy for developing a blood clot.
That sounds pretty high. So what can I do to reduce my risk of getting a clot?
Yeah, so there are some medications, pills that you can take that do reduce your risk. There recently were published 2 large randomized controlled trials, the AVERT study and the Cassini trial, which tested 2 anticoagulants, direct oral anticoagulants, apixaban and rivaroxaban, against placebo to look at their impact on risk of clot as well as risk of bleeding. And in these studies, both of the medications reduced the risk of clot by about 50%.
That sounds impressive, but are there any side effects that I should be concerned about?
No, so that's a very good question. So yes, these blood thinners do increase your risk of bleeding, although the absolute risk is small, that it's about 2% if you're taking a blood thinner versus the people that were taking the placebo is about 1%. I think the best way to think about it is there's a concept called the number needed to harm with a medication versus the number needed to treat to avoid a complication. And in these studies, the number needed to treat to avoid 1 blood clot was about 16 to 26 patients. So you'd have to treat 16 or 26 patients with the active drug to avoid 1 blood clot. And the number needed to harm somebody with the medication was around 100. So if you look at those numbers, the risk-benefit ratio really seems to favor treating to prevent blood clots because the benefits of treatment are much greater than the risks of harm.
Okay, you convinced me. Thank you. I think I should start on this to reduce my risk of a blood clot. Thank you so much for taking the extra time to talk with me about the risks of blood clots associated with cancer treatment and how I can reduce it.
It's been my pleasure. And so what I'll do is I'll work with our pharmacists to look for the most affordable medication that we can use and make sure that there are no drug-drug interactions that would put you at increased risk for side effects.
Great, thank you.
So now that we've reviewed the Khorana risk score, since the advent of the Khorana risk score and its development, there have been a number of other risk assessment models that have been developed. So I'm going to review those quickly. They include the Vienna CAT score, as you can see on this table, the PROTECT score, the CompassScore, the OncoTev score, and the TIC OncoScore. As you can see in the table, that most of these scoring systems have also included a lot of the core risk factors from the Khorana risk score. Several have included laboratory variables, either D-dimer or soluble P-selectin or SNPs that they discovered in genetic analyses. Others have included the chemotherapy the patient receives, performance status, or previous VTE, metastases, vascular lymphatic compression in the patients. The Vienna CAT score was the first score to follow the Khorana risk score. It was developed from a prospective cancer cohort of patients that either had newly diagnosed disease or had progressive disease and were getting ready to start therapy. The outcome was symptomatic venous thromboembolism. They discovered that all the Khorana risk score elements were useful in identifying patients at risk for thrombosis, but also included several laboratory variables that they found were useful, including D-dimer and soluble P-selectin. As you can see in the graph to the right here, as you had an increasing score, the risk of thrombosis over the first 6 months after initiation of therapy gradually rose, such that patients that had a risk of 5 or more points actually had a risk of 35% of developing a thrombotic event during their therapy. And so this has been, it basically concludes that this is a very useful risk model that we should consider in the future applying to our patients. The PROTECT risk assessment model was developed using the PROTECT study cohort. They included chemotherapy items, so gemcitabine and platinum-based chemotherapy were also found to be predictive of risk, and then found that patients with the PROTECT score who had 3 or more points were noted to be at high risk, where those who had 0 to 2 points were at lower risk, and then compared their risk model in the PROTECT population to the Khorana risk score. As you can see, in both using the Khorana risk score or the PROTECT score, both identified patients that were at very high risk if they did not receive thromboprophylaxis, whereas both scores performed well in that the low-risk patients did not have a major increase in thrombosis if they weren't receiving thromboprophylaxis. The CONCO risk assessment model was based on a post-hoc analysis of the CONCO study that randomized patients to either control or low molecular weight heparin and enoxaparin for thromboprophylaxis. This was a population of advanced pancreatic cancer patients that were not could not undergo curative surgery. They found that the Khorana risk score elements all were useful except for BMI in their patient population, and found additionally that the performance status of their patients seemed to influence the risk of thrombosis. If you look at the table to the right, you look at the low risk CONCO patients, that the number needed to treat went down compared to the total population, so that you had to treat more patients to prevent one thrombotic event, whereas in the higher risk population, you only have to treat 9 patients. And so they felt this was an optimal scoring system for their focused patient population, which was pancreatic cancer patients. And a prospective cohort of over 800 patients with solid tumors. All patients had baseline imaging, including ultrasound studies. If you had a thrombotic event, you were excluded from participation from the study at baseline. The risk elements they found were useful in predicting thrombosis, including a KRS of greater than 2. If you had previous thrombotic events, metastases, or on imaging, your tumor compressed either vascular or lymphatic structures. As you can see in the graph to the right, that in the OncoTev scores, you had increasing points, you had increasing thrombotic event rates within 12 months of enrollment. And then they compared their score in the OncoTev population to the Khorana risk score and found that in that population, it appeared to perform better than the KRS. The TIC OncoScore took a little bit different take on this. They looked at a prospective cohort of GI and lung cancer patients, collected clinical variables, but also genotyped patients for different SNPs that have been associated with thrombosis, and then looked at symptomatic VTE at 6 months as the outcome. The elements of the TIC OncoScore that proved to be useful were polymorphisms in factor 5, factor 2, factor 13, and then several clinical risk factors, including BMI, family history, primary tumor, and tumor stage. When they looked at the TIC OncoScore compared to the Khorana risk score, again, in that patient population, they found that the area under the curve in ROC curves was superior for the TIC OncoScore than it was for the Khorana score in their population. And then finally, the CompassCat score, recently published. This is a prospective cohort of 1,300 patients with solid tumors who were enrolled either prior to therapy or during therapy. The VTE rate was 8.6% at 12 months. These are the elements in the scoring system in the table to the right. Patients that had 7 or more points were considered at high risk, and their risk over 12 months of having a thrombotic event was 13%, whereas in the low-risk patients, it was 1.7%. In their using that cutoff, the AUC was 0.85, the C statistic in the ROC curves. And so their conclusion was that this scoring system in their patient population identified patients at high risk for thrombosis. So let's look at this prospective study. This was a prospective multi-center cohort study done in advanced cancer patients, conducted between 2008 and 2016. The objective measure, or the measure of efficacy, was objective VTE within 6 months of enrollment in the cohort. The study population consisted of 876 patients, but importantly, it's important to note that only 230 were enrolled pre-chemotherapy, which is when you're supposed to do your risk assessments. VTE was diagnosed in 6% of patients. In the table below, you can see the different scoring systems with the concordance statistics, all in about the 0.5 to 0.6 range, with PROTECT having the highest concordance statistic at 0.59. However, all of them, if you look at the 95% confidence intervals, are overlapping. If you look at patients that the risk of VTE in the high-risk patients, it was highest in the PROTECT score, lower in the Khorana score, and the ratio of high to low risk was highest with the PROTECT score at a hazard ratio of 2.1. So it's suggesting that in this patient population, PROTECT worked better than the other scoring systems, albeit only a third of the patients were enrolled before chemotherapy started. I think the ultimate goal of any scoring system is to be used in a management study, and that the Khorana risk score has been used in 2 large randomized trials of thromboprophylaxis, the Cassini trial and the AVERT trial, which were both published several years ago. This is a meta-analysis by my colleague Tzu Fei Wang that was published in JTH a couple of years ago. What you can see here are the results of those 2 studies. In the first set of bars here, you have the results for venous thromboembolism in the patients that got placebo versus got rivaroxaban, 10 milligrams once daily. You see a significant reduction in VTE, number needed to treat only 26, so about half of what we saw in the SAVE ONCO study and the PROTECT study. In the AVERT study, again, you see substantial reduction in thrombosis risk from 7.3% to 1%, with apixaban, number needed to treat only 16. When you looked at the number needed to harm, both these studies showed that it only had a modest impact on harm, and so showed that the Khorana risk score, when used in management, can identify patients that are at high risk for thrombosis that benefit from thromboprophylaxis. So that brings me to my conclusions. I hope you agree after reviewing these data that CAT is a common cause of morbidity and mortality. Really, to ideally prevent CAT, you need to identify high-risk patients. We have a number of risk assessment models that have been developed and tested. I think the goal for us in the future is to identify the optimal approaches to risk assessment so we can protect our patients that are at risk for thrombosis. Thank you very much for your attention.
Great. Thank you, Michael, for a really thorough and comprehensive overview of the landscape of risk stratification in cancer patients, specifically related to venous thromboembolism. And as you've shown, there's been a lot of literature on this over the past decade, and it just seems to be growing and growing and adding to sort of our clinical approaches to this population. It's one thing to sort of understand risk assessment and understand which patients are at risk. You know, a second, as you pointed out, Michael, is to sort of focus on what can we do about it. And so my topic today will be to discuss specifically that, how best can we prevent cancer-associated thrombosis in our patient population. Let me just sort of give you some more additional background on VTE prevention in the cancer population. which is not a new subject. It's been around for several decades. But as physicians, we actually know, and providers to cancer patients, we know this best in two settings, which we won't discuss today. The one on the left, which is major cancer surgery. So we've been doing thromboprophylaxis in patients who undergo major abdominal or pelvic surgery. Initial studies showed that it was important to do it in the immediate aftermath of the operation. And more recent studies have shown that extended prophylaxis, particularly in the abdominal or pelvic surgery, cancer surgery population, is beneficial up to 4 weeks following major resection. But that discussion has been going on for several decades. There's not much that's new. And so just recognizing that that's an important setting in which cancer prevention or VTE prevention can occur in cancer, but that's definitely one setting. A second setting where it's also common to do VTE prevention is the hospitalized cancer patient population. And although there are no cancer-specific clinical trials, other than a pilot trial that we did last year, we take data from large trials in the acutely ill medical population, which included between 5 and 15% of those patients were active cancer patients. And based on that data, we know that inpatient prophylaxis is beneficial in the setting. That also, there's nothing new about that. That's been going on for several, 2 decades now almost. And so again, that's a setting that we recognize where it's important to prevent VTE in cancer. But my talk today will focus primarily on in the setting of outpatient systemic therapy. As an oncologist, I know most of my cancer therapy is delivered in the outpatient setting. We rarely admit patients to hospital for systemic therapy anymore. And so it follows that most clots would also occur in the outpatient setting. And there's good data now that suggests that between 75 and 80% of all clots in patients with cancer do in fact occur in the outpatient setting. And so it's important to address prophylaxis in the outpatient setting, because you could be perfect with inpatient prophylaxis and you could be perfect with post-surgical prophylaxis, and you still wouldn't prevent 80%, 75 to 80% of clots. So multiple recent randomized trials have therefore addressed outpatient prophylaxis in the cancer population. Mike referred to several of those, and I want to get into a little bit of detail on the background of those trials and then look at the most recent data and guidelines. The two largest trials are sort of proof of principle that you can't just address all cancer patients as sort of a monolithic group and try and prevent VTE in this population. Those two trials are PROTECT, which enrolled over 1,000 patients using a low molecular weight heparin, niraparib, versus placebo, and SAVE ONCO, which accrued over 3,000 patients to randomize to either an ultra low molecular weight heparin, cimeloparib, which is not currently on the market anywhere, versus placebo. And in both those studies, the results were very similar. They met statistical endpoints. So the primary endpoint was reduced. But because these populations were not risk adapted, so because they took just basically any cancer patient mostly with solid tumors, the event rates were not very high. And that's shown in the table below. In PROTECT, event rate was 3.9% in the placebo arm. That actually included venous and arterial events, down to 2% with the drug. And that's a number needed to treat of 53. SAVE ONCO, it was about only VTE, 3.4% in the placebo arm, down to 1.2%. Number needed to treat is 46. So that means about 50 patients need to be injected with a daily self-injection to prevent one of them from having a clot that leads to a daily self-injection. That math certainly doesn't add up, and most physicians opted not to choose to do outpatient prophylaxis after the results of the study, nor did guidelines recommend it. But what happens when we apply risk stratification to this population? Let's look at just one of these trials, PROTECT, using the risk score. And as I mentioned, on the left is 3.9% down to 2%. That's a number needed to treat of about 50. But this trial included several patients who were in fact at low risk of getting venous or arterial thromboembolism. And if we look at just that low risk population, score of 0 to 2, number needed to treat actually climbs even further, 77. But if you separate out the high risk population, and that's defined in this study as a 3 or higher, then the absolute risk difference is much greater, 11% down to 4%. And the number needed to treat is much stronger, about 15. And that's very similar to the number needed to treat for postoperative prophylaxis, where we've commonly been using it. And so if you use risk adaptation, not only do you spare low-risk patients from getting prophylaxis, you also target high-risk patients who really are the ones who are most likely to benefit from this. In a pooled analysis that we conducted of several different trials, including SAVE ONCO, PROTECT, and FACTS, We also found similar results. The relative risk for VTE with prophylaxis is down to 0.4 with a highly significant p-value if we focus on the high-risk population. But these were retrospective analyses of prospectively done study with the exception of facts, which did not accrue fully to its targeted enrollment. And so these data were taken into account by the guidelines, but not really mandated. What changed was in 2 years ago when two separate independently run trials were reported out in the same issue of the New England with an accompanying editorial. One was, I had the privilege of leading with called Cassini using rivaroxaban along with Mike Streiff and many other investigators. And the second was led by Mark Carrier and Phil Wells from Canada and used apixaban to prevent VTE in population with cancer. And let me just go over the study design of these two trials to get into some more detail on this primary prevention approach. Both these trials took newer data, which was emerging at the time, but has now since been validated, suggesting that a score of 2 or higher, in fact, does identify a high-risk population. And so in AVERT, patients with a newly diagnosed cancer or starting a new treatment with a Khorana score of 2 or higher were randomized to apixaban 2.5 milligrams twice daily or placebo for a period of 6 months. The N was 570 patients, and the primary endpoint was the first episode of a VTE that had to be documented by imaging, and the imaging was reviewed by blinded investigators centrally. And patients were followed for a period of up to 7 months. Cassini also had a very similar study design, new diagnosis or new treatment for solid tumor or lymphoma. At the time of starting a new treatment, a score of 2 or higher, randomized to rivaroxaban 10 milligram once a day or placebo. The only sort of twist here was that we added a baseline ultrasound before randomization, and we found about 5% of patients already had a blood clot before randomization. And unfortunately, although this helped select out patients who already had a blood clot for appropriate treatment, unfortunately, it reduced the power of the study to find enough events. So let's look at the results. For AVERT, there were 28 events in the placebo arm, down to 12 events in the apixaban arm. That's a substantial absolute risk reduction, 10% down to 4%. That's what the score would have predicted, by the way, was a rate of VTE of about 10% for patients with 2 or higher, and that was met. In addition, very clinically meaningful events were prevented. There were 16 events of pulmonary embolism in the placebo arm, down to 5 in the apixaban arm. That's a 2/3 reduction in pulmonary embolism, which I think we can all agree is very meaningful for cancer patients. Overall reduction of VTE, the number needed to treat was 17, which is kind of what was predicted based on the subgroup analyses of PROTECT and SAVE Onco. And so confirming sort of our prior understanding of VTE prevention in this setting. In Cassini, the results are a little bit more challenging to understand. As I mentioned, many patients had, all patients had a baseline ultrasound. And so as you can see, the curves don't really separate because people who presumably would have a clot developed very soon after randomization were already picked out of the pool because we had that baseline ultrasound. And so you don't really see a separation of the curves until a little bit further down the road. There was a reduction of primary endpoint events with rivaroxaban, but it was not statistically significant. There was also a high sort of drop-off rate because of people going off the drug. If you focus on the intent to treat population for the intervention period for the time frame that patients were actually taking the drug, there was a statistically significant reduction, and the number needed to treat is 26. And then if you add in secondary efficacy endpoints, which included arterial events, then the number needed to treat drops even further to 21 in the up to 180-day population, and 17 if you focus on the intervention period while patients were actually taking the drug. So again, sort of confirming our pre-trial assessment that was sort of a number needed to treat that we were aiming for. Obviously, you don't want to use a primary prevention approach that causes harm. And here, thankfully, the results of both AVERT and Cassini are very consistent. On treatment, so while patients were taking the drug, the increase in major bleeding was an absolute increase of 1%. A number needed to harm for both of them was roughly 100, which in this setting is considered to be highly acceptable. Where there are trials, there are meta-analyses. So here's the meta-analysis of DOACs for primary prophylaxis, separating out the population by a score of 2 or higher, or by the older standard of 3 or higher. And as you can see, overall, putting all these trials together, the number needed to treat is 25. And it goes up to number needed to treat, or down, I should say, to 17 for patients with a score of 3 or higher. So the higher the absolute increase, the greater the benefit to patients. Major bleeding, no real signal there. The number needed to treat harm overall is about 1,000. And doesn't seem to vary significantly based on score of 2 or score of 3 or higher. And mortality was certainly not worsened and may actually have improved. Number needed to treat is overall 36, but as you can see, those confidence intervals overlap. So again, providing reassurance that we are seeing consistent data, we are not worsening harm to patients, we are not worsening mortality, and in fact, maybe benefiting mortality approaches. And overall, the number needed to treat is in the range of where we would accept this type of an intervention. Cost-effective analyses also confirmed that incremental cost and quality increases were acceptable, and the drug was deemed 94% cost-effective at a threshold of $50,000 per quality-adjusted life year. And people with a Khorana score of 3 or higher had even greater benefit, as you would predict, because they had a greater risk of getting blood clots at baseline. So here's the updated guidelines for primary prevention. As you can see, they're actually very consistent across all of these guidelines. ASCO, NCCN, ITAG, ISTH, ASH all now recommend that primary prophylaxis be considered or recommended in patients, ambulatory cancer patients. So these are outpatients that are about to start a new systemic therapy and have a score of 2 or higher. Obviously, if there's concerns for bleeding or if there's other drug-drug interactions, we should not offer it. But for many, if not most patients with this score or this risk of getting VTE, this should definitely be a consideration. Next step is to actually translate these guidelines and these clinical trials data into practice. Very quickly, there's a couple of prophylaxis implementation models. Here at the Cleveland Clinic, we've created an electronic medical record alert that alerts the treating oncologist. So it automatically calculates the score, tells you that your patient has a score of 2 or higher, and asks you to consider prophylaxis if your patient is not at high risk for bleeding. In Vermont, there's an EMR alert that actually leads to a heme or pharmacy consult. And they've been using this now for about 2 years. And they found that for patients who are referred to hematology, almost 94% of patients actually did receive prophylaxis. And I can think of a better set of compliance numbers. And I think this tells us that if we have a good informed discussion with the patient, we prioritize this discussion, we reduce the burden on oncologists to have this discussion. So, developing a new model of prophylaxis care that patients and physicians will in fact opt for prophylaxis and will be compliant with prophylaxis. So something to consider as we think about knowledge translation. So to summarize, I believe we are now at a new paradigm for primary prevention. Cassini and Evert confirm and extend the benefit of low-dose anticoagulation for primary prevention in high-risk patients, confirmed by now new guidelines. I've talked briefly about practice implementation approaches that really need to be applied nationwide. And our goal should remain to reduce the public health burden of cancer-associated thrombosis. Thank you very much for your attention. And I will now pass the baton on to Dr. Tzu Fei Wang, who will talk about treating VTE in your patients with cancer.
Thank you, Dr. Streiff and Dr. Khorana. And thank you for the invitation for me to allow me to present to you today to the last part of our discussion. As you have already heard from prior discussion that cancer patients really are diagnosed with a lot of thrombosis. Up to 20% of cancer patients throughout their journey can be diagnosed with thrombosis, and therefore it is important to really learn to know kind of how to treat them and learn about it. So when we start thinking about how to provide the best or optimal anticoagulant for patient, there are usually the 4 steps: risk approach, risk adaptive approach, or 4 kind of different factors that we will be thinking about. And I will address each of them in the following 20 minutes or so. That includes the type of tumor, and is there any additional risk factors to consider, including intracranial tumor, thrombocytopenia, or certainly discussing or thinking about the potential drug-drug interaction, as well as last but not least, patient preference. First, I would like to discuss the data supporting the efficacy and safety on using DOAC in treating cancer-related thrombosis. I'm sure this audience familiar with the four main randomized controlled trials that really established the role of using DOAC really ever since 2018 when the trial results came out. So the trial design are pretty similar, as you can see here. All the four trials are randomizing to direct or anticoagulant respective ones with standard dose. Hokusai studies using edoxaban, Select-D study using rivaroxaban, and Adam VTE and Caravaggio studies using apixaban versus Delta parent. Again, you can see here standard dose. They all include active patient with active cancer, most of them with malignancy diagnosed or treated within the past 6 months. Although Hokusai and Caravaggio study did include up to history or diagnosis of cancer of 2 years, but more than 90%, 95% of those patients actually have active cancer. The majority of these patients have proximal lower extremity DVT or PE, except for a very small percentage of upper extremity DVT or splenic VTE included in the Adam VTE patient study. And the majority of them, actually all of them, exclude the patient with platelet count less than 50, which we'll have a discussion later about how to manage those patients with thrombocytopenia. Some trial even have a higher platelet threshold, such as Caravaggio study with a platelet threshold of 75 and Select-D study of 100. All studies really exclude the patient with renal insufficiency with creatinine clearance less than 30. And all the trials really treated patients for at least 6 months, with the only exception is Hokusai study does go out to 12 months, although everybody should be treated at least 6 months in that study. And the primary endpoint is slightly different, but the main endpoint is recurrent VT as an efficacy outcome and major bleeding. They are all by ICH standard criteria for major bleeding safety outcome, which I'll show you next. So when you combine the meta-analysis, combine all the results together, you can see that the DOAC overall is significantly reduced the risk of recurrent thrombosis at 6 months, with a relative risk of 0.62, which means 40% risk reduction compared to low-molecular heparin. In the meantime, DOAC is associated with a non-statistically significant but increased about 30% increased risk of major bleeding compared to low-molecular heparin. Then what are really those major bleeding? So in the early trials, including Select-D and Hokusai study, there's a signal about major GI bleeding. Therefore, when you combine all the trial together, looking at major GI bleeding, you can see that although it's not statistically significant technically, but there's really a strong trend with overall almost close to twofold increased risk of major GI bleeding and associated with DOAC. And these are, a lot of them are patients with GI tumor that are unresected in the intact luminal GI tumor. How about GU bleeding? So we do notice that a significant increased risk of major GU bleeding associated with DOAC. You can see it's almost 5-fold increased risk. However, I will caution that as you can see, the confidence interval is quite wide because as you can see, the number of events is really quite low, mainly because the number of patients in the GU subset, GU tumor subset in each study is really quite small. But these are certainly kind of tell us how to what kind of tumor, what kind of patient characteristic to decide on your treatment. This is a slide for summary of all the major the 5 major guidelines that's all been updated, courtesy Dr. Khorana slide. As you can see here, that really all the major guidelines have updated to include DOAC to be a appropriate initial treatment for cancer-associated thrombosis, including rivaroxaban, edoxaban, and apixaban, based on the trials results that I just presented to you. And the duration of therapy, we actually will spend another few slides later to discuss. All the trials, all the guidelines really recommend at least 6 months because that's the most data we have from clinical trials. But to extend it if the patient cancer is active and or continue active cancer therapy. So next, we'll look at the video on an update on our patient, Mrs. Smith, if you remember on Dr. Streiff's talk. about this patient. So this patient unfortunately was not able to start thromboprophylaxis due to insurance issue. So 2 months into her chemotherapy, she developed chest pain, short of breath, and lower extremity swelling, and was diagnosed with PE and DVT. She was started on standard enoxaparin dose and is seeing you for follow-up. So let's watch the visit again. So, Mrs. Smith, I'm very sorry to hear that you had to go to the hospital last week. I'm sure the hospital doctor have told you that what happened is the image study did show that you end up developing blood clot in both the lung, we call pulmonary embolism, and blood clot in your left leg, we call deep vein thrombosis. And both of them would explain your symptoms. So how have you been feeling since you got out of the hospital?
Well, I'm feeling a bit better now, but still short of breath when I get up. And my leg is still swollen and hurts when I walk around.
Yeah, I'm glad that you're feeling a little better. And again, those are the symptoms of blood clot that I would anticipate that most patients would continue to improve in the next few days to a week or two, as long as you continue on the blood thinner. I understand that they gave you the blood thinner injection right now called enoxaparin. How are you doing with that? Any bleeding issues?
Well, no bleeding issues, but the injections are starting to bother me. I'm getting a lot of bruises. Are there blood thinner pills that I could take? What about the blood thinner pills we talked about a few months ago?
I'm sorry to hear that the injections are bothering you. We certainly have blood thinner pill that the rivaroxaban and apixaban that we discussed before that we can use to treat your blood clot, not just to prevent it, just with a higher dose, as we talked about. But some of the pills, especially the rivaroxaban, really in the research studies have been shown to increase risk of bleeding, especially in people like you who have colon cancer or have cancer in the gut. With that said, though, that's mainly in people whose cancer has not been resected and mainly in the gut. For you, your tumor is mainly in the liver, and on the CAT scan, and as far as we know, there's not a big tumor in the gut. So I do think that if the injection really bothers you, it is worth that we can try one of these pills. But I do want you to understand that there is a increased risk of bleeding potentially, so that you can, certainly watch out for signs and symptoms bleeding, and let us know if you have those.
Well, the injections bother me a lot, so I would like to give the pills a try.
Okay, I understand. Then I think I would suggest that we try the Pixaban, because even though there's no head-to-head comparison of different pills, they all have been compared to the injection, similar to the one that you're being on. And Pixaban really has been the one that hasn't shown any bleeding. So I would suggest to try that.
Sounds good. Thank you.
Okay, good. Now go ahead and get the prescription ready for you. The dose will be 5 milligrams of 1 tablet twice a day. We can go ahead and make the change.
Great.
So, thank you. So as we kind of alluded in the video, and also initial the 4 step that if you remember the slides, that patient preference certainly is very important. Dr. Simon Noble from the UK actually published a good, really good quality study on interviewing patient with cancer-associated thrombosis, and these are the top 3 kind of preference for patient. Number 1 being when we choose anticoagulation. Number 1 being no interference with cancer therapies, because these patients really consider themselves as cancer patient and not clot patient first. And even after that, they will consider good efficacy and safety profiles for this anticoagulant, and really the least, not the least, but even after that, it will be the route of administration. So those are the acute treatment. What about chronic treatment, as we touched briefly upon on? So major guidelines really have recommended at least 6 months of anticoagulation, but beyond 6 months, most guidelines recommend to continue anticoagulation as long as the cancer is persist and treatment is persist. Now, turns out we actually have very little data beyond 6 months, and HER2-CVD cancer study is really the first prospective randomized controlled trial that have data beyond between 6 to 12 months. As you can see here, the outcome, including recurrent and VTE and major bleeding between the 6 and 12 months in both edoxaban and dalteparin arm is actually quite low. So that's encouraging. But the conclusion is it's still the risk factor of cancer and treatment is still persist. So continuing anticoagulation beyond 6 months still the standard recommendation, and DOA is really being very appropriate choices. Now the new kind of area is really to look at if we reduce dose of DOA, such as what we use for the general population based on the Einstein choice study and Amplify extension study, would that really provide a safer, however, continually effective options? So these are the two main studies that I'm aware this still is ongoing currently for recruitment. Both are using apixaban, EPICAT study and EVE study. Both are studying cancer patients after finishing at least 6 months of therapeutic anticoagulation and randomize them to standard apixaban dose 5 milligram twice daily versus a reduced dose 2.5 milligram twice daily. So we're hoping that we'll have results in the next few years, so that will help us manage these patients, because these are quite a big percentage of patient population. So I want to really talk about some special population that really happen uncommonly, not uncommonly, I should say, in cancer population, and sometimes can be quite challenging. The first population is patient with brain tumor. So before we do that, we will have a final visit with our patient, Mrs. Smith. The patient was started on apixaban, really no bleeding issue. However, 3 months later, she did unfortunately presented with new neurological symptoms, and the head CT showed multiple intracranial brain mets. She's referred to radiation oncology and for appropriate treatment for her new diagnosis of brain metastasis. And she's also came back to see you for follow-up. So let's look at the video again. So Mrs. Smith, I'm very sorry to say that the image has shown that your cancer is progressing. I know you're going to start radiation therapy soon to the brain, and I agree that that's the right next step for you.
I'm scared, doctor. They told me that cancer in the brain bleeds easily, and I don't want to have bleeding in the brain. Do I need to continue to take the blood thinner now that I've taken it for 3 months?
No, I totally understand your concerns, Mrs. Smith. I would recommend you to continue the blood thinner at this time, because we your blood clot is really related to your cancer and its treatment. And since the cancer is still there, and if anything is doing a little worse, we really are worried that if you were to stop blood thinner, you'll be at a very high risk for another blood clot. I totally understand the concern of bleeding in the brain, and we do have quite some studies show that even in patients with cancer in the brain on blood thinner, they don't really have a higher risk of bleeding compared to those patients who are not taking blood thinner. However, not being on blood thinner will really have a very high risk of having another blood clot. Although we don't have as much information for the pills that you're taking, but the available studies so far also have shown that the pills really does not increase bleeding compared to the injection. So with all these consideration, I would suggest you to continue the blood thinners at this time.
That makes sense. I'll continue the blood thinner.
Yeah, certainly let us know if there's anything change or any other concerns.
Thank you.
Okay, so the patient with a brain tumor certainly have a very high risk of intracranial bleeding. That's when people are very concerned about. So I want to show you some data, and this is a summarizing slide. I'll show you the data in the next few slides. So these are the meta-analysis done by Dr. Jeff Zwicker and colleague. So as you can see here, and Dr. Zwicker done a lot of this work. It turns out we don't really have a lot of good data. A majority of data is coming from retrospective study. As you can see that for metastatic brain tumor patient, comparing treating them with low megaheparin, these are the majority of anticoagulation back then, versus no anticoagulation. Really, low megaheparin does not associate with increased risk of bleeding. However, the primary brain tumor glioma is a different story. Low megaheparin is associated with about 3 to 4-fold significantly increased risk of bleeding compared to no anticoagulation. Now, how about in the DOA era? So again, from Dr. Switzer's group, that you can see again in two different cohorts, primary brain tumor and metastatic brain tumor. When they look at in their patient population comparing DOA versus lomboca heparin, you can see that DOA really does not seem to have increased risk of bleeding as compared to lomboca heparin. But I will caution, to not to overinterpret this number, because as you can see that the number on DOAC is really quite small, only 20 patients in each cohort. It just speaks for that we certainly need more data. There's an ongoing multi-center international retrospective cohort study that's led by ISTH SSC. So hopefully to answer this question in the next year or two. Now, how about patients with potential drug-drug interactions? As we all know that DOAs are substrates of two major pathways, PGP, the P-glycoprotein, or CYP3A4. And it turns out different DOA also have different pathway. Rivaroxaban and apixaban particularly are metabolized in both pathway as compared to edoxaban and dabigatran only in the PGP pathway. And as we all know, a lot of cancer therapy, especially tyrosine kinase inhibitor, can also go through either or both pathways. And if any of those cancer therapy are a strong inhibitor or moderate inhibitor, it can increase DOA concentration and causing bleeding complication. On the contrary, if they are inducers, they can reduce the DOA concentration and causing thrombotic event. Because of that, you can see these major guidelines really cautions against concurrent use. However, you can see that there's really no details about what specific drugs to avoid combination use. There's really for a good reason, because we really have very limited data. Up to this point, a lot of them are case series or just case report. So we certainly need more data. I know recent Caravaggio study had a secondary analysis, but when you really look down into the detail, is only 30 patients on concurrent apixaban and selective target cancer therapy. There's only 30 patients over 15 different kind of TKI. So again, we certainly need more data. And just want to put in the plug that we actually recently completed TechDOA registry sponsored by ISTH, that the result will be reported at ISTH in July of this year. So please stay tuned for more data. Now, how about patients with thrombocytopenia? As we all know, thrombocytopenia is common, could be due to cancer therapy or cancer itself, such as in leukemia or MDS patient. And turns out we also have very poor data. Most data, there's really no prospective study so far. All the data is from retrospective study. And these are, really some guidance from ISTH published in 2018 that I personally also follow. Usually for patient over with platelet count at least 50, therapeutic anticoagulation is considered appropriate. Less than 25, we will hold. If the platelet count is between 25 to 50, it really depends on how you perceive the progression with clot risk is. In a high-risk patient, including PE or lowish mid DVT with acute clot, then the suggestion is therapeutic dose of anticoagulation plus platelet transfusion. If it's a lower risk of thrombus progression or subacute, that includes upper extremity DVT or distal DVT, then the suggestion is to reduce dose of therapy. Again, I would say that this is really not based on really good quality data. So we certainly need more data. And at ISTH, we will have a multi-center US study called TROPH study. That's one of the first prospective study that will report our result about patient with thrombocytopenia needing anticoagulation. So again, hopefully we'll provide more guidance on this. The other situation is a patient with central venous catheter that's really quite commonly used for chemotherapy infusion and or transfusion. So primary prevention in these patients has not been routinely offered, not for the lack of efficacy. There's actually some study done with lomboca heparin is quite effective. However, the burden of daily injection and also the risk of major bleeding is also unclear. So it certainly is a ongoing active area of research on using using DOAC for this population as primary prevention. How about treatment? If a patient were to develop a catheter-related thrombosis, the treatment usually is extrapolated from lower extremity DVT. So low molecular heparin has been the standard. In recent years, of course, people are using DOAC, but keep in mind that DOAC really in the major trials, these patients are actually excluded from the study. So there's really very few prospective study on using DOAC for these. Catheter 2 study that was run in Canada is one of them. It's a very small 70 patients treated with rivaroxaban. You can see that at 12 weeks, the recurrent VTE risk is low, but major bleeding is quite high, is 10%. So it is unclear with that whether that is, we certainly would need more data. Last but not least, cancer patient commonly developed recurrent VTE while anticoagulation. A lot of times this is when their cancer is progressing. And again, we also does not have really much prospective data, let alone randomized control trial data. A lot of these are from retrospective, single center retrospective study. And most time, we will, if the patient is on warfarin, we'll switch to low molecular heparin, given the trials show that low molecular heparin has better efficacy. If a patient is already on low molecular heparin, then there are some retrospective studies show that escalating their dose by 20 to 25%, at least in the first month or so would be appropriate. But I think it's quite interesting to see how people will manage if those patients are already on DOAC, because we do know that DOAC is shown to have more efficacy than low molecular heparin. I would say that currently a lot of patients are still being switched to low molecular heparin, but again, we really don't have a lot of data, and hopefully in the coming years, we'll have more data to help us to treat these patients.
So I think we have time for a few questions. And I'll bring my co-presenters in here. So Drs. Wang and Streiff, if you could unmute. So here's one for, I guess, both of you. So in your own practices, do you choose amongst the different DOACs on a case-by-case basis, or do you tend to have a preference? Tzu Fei?
Yeah, as I've discussed, I usually go through those kind of 4 different factors, and when I think about the anticoagulant choice, including low molecular heparin is always also the choice. If the patient have high risk of GI or GU bleeding, then I would choose to start with low molecular heparin, more tend to start with low molecular heparin. And if patient doesn't really have any other, and I'll routinely check drug-drug interaction and all that, and if patient doesn't really have any other contraindication for DOAC, and renal function, everything is good, and platelet count is good, I will start with DOAC, and I tend to start with apixaban, just because, not that I would acknowledge there's no head-to-head comparison of different DOAC, but just based on the Caravaggio study and Hakuse and Saleh study, apixaban seems to have the most safety, the best safety outcome.
Great, thanks.
That's my personal practice, yeah.
Mike, did you want to comment on how you choose?
No, I think her approach is great. I mean, I think you should do all those things. Look for drug-drug interactions and GI, GU involvement. And I have preference for DOACs. If I use a DOAC, I generally choose apixaban as well. But looking at all those different options, and also insurability, you know, if it's covered or not.
Right. Not a problem for Tzu Fei, but here in the US, we do have to go formularies.
Well, actually, we only cover for 6 months. So yeah, beyond 6 months, sometimes it's a problem.
All right. I guess I should have started at the earliest question first. So what was the lower age limit of trial participants, and are there any scoring systems for pediatric populations? I think across these studies, it was 18. There are developing scores for the pediatric population for VTE, but I'm not aware of any that have been validated or that are being clinically used. Next question is, do any of the panelists know if today's discussion pertains to head and neck cancer patients? So Mike, you know, in the risk discussion, I guess head and neck cancer, you'd get a score of 0, but you could still get to high risk by having like a high white count or high BMI, right?
Sure, yeah. I mean, there weren't many head and neck patients in most of these studies, but I think that they're at risk. And so if they you know, on a Khorana risk score, if they should be considered for prophylaxis, I would consider them, so. Yeah.
So I think this next question is pertaining to my subject, which was about AVERT. So it says no difference was seen between apixaban and placebo while on treatment. While I'm assuming they mean due to safety. So I understand evaluation of efficacy should be based on intended drug period. Safety should be based on the true period of treatment. I completely agree. And if you look at the true treatment period, you're right. So once apixaban was stopped, and people are followed for a couple of days afterwards, there was no increased risk of bleeding, statistically significant increased risk of bleeding. There was a 1% absolute increased risk of major bleeding. These studies are not powered to show significance at that level. You need like 3,000-4,000 patients to show a 1% difference between groups. So I would still assume that 1% increase is real, but that still, translates into a number needed to harm of around 100, which in most primary prevention approaches would be considered appropriate. And also note that mortality was no different between the two. Across these studies, mortality was no different and in fact favored using anticoagulation versus not. Next question, Dr. Wang, a patient with brain metastases, one more option should have been included. So this is the case you discussed, Tzu Fei.
Yep.
It says, should you have included an option of no treatment at all and insertion of IVC filter?
I think
that often comes up. Maybe, did you want to address that?
Sure, and I think there's another question about IVC filters, so maybe I can address both of them together. The reason I didn't include that is because, based on the data that I've shown you, really anticoagulation, especially for a patient with a brain metastasis like he has, and I would argue that his brain metastasis has also been fully treated 3 months ago, and he never had a bleeding issue. So, and then really according to the meta-analysis in the retrospective study, we have not really shown that for a brain mets patient, they have increased risk of bleeding when you use anticoagulation compared to no anticoagulation. And then, DOAC really compared to lenacapavir also has not increased risk of bleeding. We do know that if we don't give them anticoagulation, their risk of recurrent thrombosis, especially proximal DVT, is really quite high. So I personally practice, and that's my colleagues practice as well, that we really only use IVC filter for when we absolutely need to, which means when patients are actively bleeding, which that patient did not. And also there's an absolute contraindication, and we are trying to use it as short duration as possible, that we use during that short period of time patient cannot tolerate anticoagulation. But as soon as they can tolerate anticoagulation, we will put them on anticoagulation and remove the filter, because the filter is really, if anything, is adds to the thrombogenic effect, is really not treating the blood clot.
Yeah, and I sort of always use the line that a retrievable filter is only retrievable if you actually retrieve it. So, in the US, I think the majority of filters are actually never retrieved. So the next question is about scoring. Michael, are there any scores for liquid tumors? I guess it's the myeloma risk scores, right?
Yeah, there are, and I didn't get into that. In fact, I didn't. There are lots of scoring systems out there. I couldn't include them all because of 20 minutes, to go over everything. But there's a Thorley for lymphoma. There's, Impede VTE for myeloma. There's the SAVE score for myeloma. So I think there are scoring systems for specific tumors, and I think we just need to collect more data. A lot of these have not been subjective to management trials like the Khorana risk score has. So I think that's where we need to go.
Next one's also for you, I think, Michael. With such a significantly increased risk with prior VTE, why is this not part of the calculated scores, and should it be added into consideration?
Yeah, so I think it's come up in one of the scoring systems. It came up in I believe it was the OncoTev, I think, found it, but it hasn't been found in other scoring systems as a risk factor. The data from Mulder looked at a very large population of patients, so that's maybe why they found it. So I think that we need to see if it comes up again. I think it's something we should consider, though.
Yeah, I agree. It's a little bit challenging in trials because most people with prior VTE are on therapeutic anticoagulation, so they end up being excluded from some of these trials. So you end up with very few patients that actually have a prior history of VTE. But I definitely consider it as an important risk factor. Would you give prophylaxis to patients on immune checkpoint inhibitors, immunotherapy for cancer?
Yeah, well, I think we know that targeted, immunotherapy is at risk. So I think we should put them in the basket with all other therapies for prophylaxis. So if the patient's at risk, they should get prophylaxis.
I agree. And, there's been actually a slew of data looking at immune checkpoint inhibitor therapy and rate of VTE. We just published a very large cohort of about 1,600 patients. We found a 20% plus risk of VTE. But it's interesting because on immune checkpoint inhibitor therapy, in most other cases, you see sort of this front loading of the risk. So most patients get clots in the first 3 months or first 6 months. Immune checkpoint inhibitors, they're highly successful drugs in treating cancers, at least in the right subgroups. And so people can live for a couple of years, and the risk for VTE and arterial events is distributed across a couple of years. So there's not a front loading where they're at a high risk. It sort of persists over a period of time. And it impacts survival. We showed that in our trial or in our cohort study. And then the Vienna group also had a cohort study where they showed the same thing: high risk of VTE, high risk of ATE, and association with worsened survival in patients receiving immune checkpoint inhibitor therapy. I think that's really fascinating. I don't know that we fully understand why, activation of the immune system leads to thrombosis and why it worsens survival. And so watch this space. I think there's going to be more data around that. Post-operative prophylaxis for breast cancer patients, for how long, and is there a dedicated score? This
I don't think
not a score that I know of. What do you think, Michael?
No, I don't think. I mean, I think that. Well, I guess there's the Ottawa score for like clot risk after you've had a clot, looking at prognostication, but not for primary prophylaxis, to my knowledge. So,
yeah. And the extended prophylaxis is more. The data are more for the abdominal and pelvic surgery.
Yeah. There's not. I don't think there's any breast cancer, mastectomy trials at all.
So I think we've addressed, unless I'm missing something, I believe we've addressed all the questions here. Well, so I think that brings us to the end of this presentation. We're a few minutes over, so apologies for that. But thank you for being such an engaged audience, both with the interactive questions and with the with these questions that you've submitted. I want to thank our panelists, Dr. Streiff and Wang, for participating and spending so much time on creating these very comprehensive overviews of risk stratification, treatment. And I want to thank again our sponsor for funding this educational activity. There's additional modules regarding this activity that you can see from ISTH and the high-tech CME. And thank you very much for taking time out of your busy day and busy evening to join us, and enjoy the rest of the ASCO meeting. Thank you.